Thank you for attending today's session. It's being presented by Dr. Steve Ollerton, and the topic is hypertension management using West Yorkshire Healthy Hearts guidance. The session will be recorded, just to let everyone know, and there will be a feedback form at the end of the session that we'd really appreciate if you could fill out. So thank you very much, and I'll pass over to Steve. Thank you.
Thank you. So I'm just looking, there's certainly some people I know on this talk already, so that's good. So yeah, I'm Steve Ollerton. I'm actually a GP in Skelmanthorpe, which is Kirklees, Huddersfield, don't know where you know, but there you go. In a previous existence, I was the clinical champion for West Yorkshire Healthy Hearts, although I'm not doing that, I'm a clinical director now, but I was asked to come and give a presentation on the Healthy Hearts guidance, particularly around hypertension, and obviously a bit of a refresh of what can be done with it now, in the light of some new kids on the block, as it were, with lots of clinical pharmacists, both in practice and in the community, and other members of the practice team, and obviously still a very big workload of hypertension in practices in your patients. So, I mean, the first, I suppose, what I could say is I'm not a GP with specialist interest at all. As I say, actually the guidelines were put together by cardiologists and other very clever people 5 years ago, and obviously I was part of the discussions and all of that, but the guidance, has not changed. I can obviously I'm going to talk about why the guidance is still relevant and how it can still be used. And I'm happy to take questions about it, but ultimately the guidance hasn't changed from what was released pre-COVID, but it is still very relevant, and particularly as NICE guidance changed last year. Fortunately, still relevant. Although, as I will discuss later on, you'll probably notice that NICE guidance moved more towards the West Yorkshire Healthy Hearts guidance, based on conversations they had with us, actually. So that's good. For those of you who may be expecting a brand new set of guidelines, or if you've heard me before, I'm not going to be saying anything different. But anyway, I'll get started, and hopefully you'll all learn something about how you might be able to work this guidance in your practice, but probably more importantly within your PCN as well. So let's move on. So the main aims of the Healthy Hearts guidance was to increase the prevalence of hypertension, and you'll be surprised just how many patients are out there who are not on your hypertension register. And certainly the Healthy Heart searches can help you identify those. But also the second part of it is about optimizing the treatment of those who are actually on your register but are not being treated to target. So, and I suppose another thing to say at this stage is the main aim of this guidance is almost industrializing the process. The idea of this is to get as many people as possible either on the register or being treated to target, because every practice has got hundreds of patients that fit into one of those two categories, and it is a constant battle that will never go away. This is just some tools that will help you maximize the number of people that you can reach. And as I say, and certainly across West Yorkshire, although I haven't brought any recent figures from Healthy Hearts, and that's because there aren't any recent figures from Healthy Hearts. But certainly, while the scheme was running for a few years, we were getting, certainly many thousands of patients onto the disease registers. and therefore being part of the sort of cough recall systems and getting better managed. So yeah, here we go. So I know this is probably a little bit small on your screen. I'm a System 1 practice, and certainly every practice in West Yorkshire, be they System 1 or EMIS, does have access to the West Yorkshire Healthy Hearts searches. This is where they are in Kirklees, I can tell you that much, but they're definitely available in all parts of West Yorkshire. As I say, both System 1 and EMIS, and they're generally found under Healthy Hearts, so you can actually look in the search and find them. And just going through them, you can see that to start off with, the first search is looking, going through finding patients who are actually on what you might deem antihypertensive medication, but are not actually on your register. The second lot of searches, so 2A, B, C, and that, are actually looking for patients who have got high blood pressure, essentially, with systolics, and diastolics very high, but are not on your register. And then the third set of searches is looking at those who are on your hypertension register, but are not optimized for treatment. And therefore, and splitting them down into, a systolic of over 180, 160, 140. So clearly, starting at the top and working down is a thing to do. But I'll just move on, because I go into the searches in a bit more detail now. So I actually ran our figures last week. We try to run them every month in my practice, but certainly. So looking at the very top one there, on antihypertensive medication but not on the register. So I've currently got 30 patients. I'll explain who those 30 patients are in a minute, but that's actually pretty good. When we first ran that search a few years ago, we were at well over 100 patients and the reason for that is generally they've not been coded by the clinician that was involved in their treatment. It's as simple as that. So started them on amlodipine or an ARB or whatever, but just didn't actually put them on the hypertension register. But just by doing that and cleaning those up and putting them on the register is a very good start. As I say, we probably reduced our number by about 70 just by doing that. As you can see, in the 2A, 2B, 2C, etc. patients. So I've got one patient there who has several high blood pressure readings in the last 3 years and a systolic of over 180 and are not on my hypertension register. I called that patient in. But it's quite surprising how, as I say, we run these searches quite often and you do get these patients pop up. Again, in the 160 to 180, I've got 4 patients who've got a systolic in that category and are not on my register. So again, should be prioritized for bringing in really and seeing what's going on there. There may be good reasons, why that is. They might have just had an erroneous, but it's not just one reading this is based on. It is based on several readings, with the most recent one being very high. And then looking at the what I call the third item. So I've got 215 patients there who are on my hypertension register and have not been reviewed in the last 12 months. They obviously they should be part of QOF and we should be bringing those in. So they are work to do. I mean, you're never going to get all your patients to come in, we know that. But again, then looking, breaking it down is the ones who've got very high blood pressure, and not treated to target. So again, I've got the figures of 3, 34 and 149. Certainly the 3 and the 34 ought to be making some greater effort to get those in, because they're clearly not to target. I think we're probably all too busy to go chasing the 149, but it's useful to, as a prioritization, keep your eye on these. And then those 29 at the bottom are the ones where actually the systolic's all right, but it's actually the diastolic that's raised over 90. So those 29, you could argue, probably, that number needs to be kept low, really. So yeah, that was my last week's figures. I think they're okay, but you know, it just shows you that the work is there all the time. So yeah, the should be about 0.2% of your list size. That's 2 in 1,000 patients. So these are the patients who are on antihypertensives but not on your register. And these are you'll never get this to naught. It shouldn't be naught. Candesartan for migraines, nifedipine or amlodipine for Raynaud's, and quite often you might just have patients on an ACE or an ARB because they've got CKD, but you haven't coded them as CKD. So this is picking them up anyway, because the search should exclude CKD. But if you put somebody on ramipril or losartan because they've got CKD and haven't coded them, they're going to turn up on this search. So again, it's just about sorting the coding out. But you should be aiming for 2 in 1,000 of your list size. That's about where the very small cohort of patients who for very good reasons are on antihypertensives, but not coded as hypertensive. I mentioned earlier that I think this work is quite useful to be done as a PCN. Certainly over the last couple of years, I've produced league tables, just to point out, because I have access to all of the clinical systems in my PCN, so we can run these searches and see what's going on. Obviously, when I ran this, Skelmanthorpe there at the top had naught, which was good. And I call these the danger patients. These are the ones with the systolic of over 180 who are not on your hypertension register. So by producing these league tables, you're kind of shining a light on your neighbouring practices. So yeah, clearly Shepley had one and Lepton had two that they need to go and find. But I think it's quite useful. I think practices are inherently competitive with each other, and they don't like to see numbers in the wrong place, as it were. So by just producing these tables and then doing it again 3 months later, I think I did manage to change the way people were, managing their patients. I like to think they were anyway, and certainly we got our numbers right down in my PCN. By regularly running these searches and just getting the patients in and reviewing them. And as I say, you'll be surprised how many do pop up on a month-by-month basis, just because they do. For those of you who haven't been on the Healthy Hearts website, this is it. Not the snappiest of titles, but if you just put West Yorkshire Healthy Hearts into Google, this is what comes up at the top. It's a really good website. I'm not just saying that. It's good for both professionals and for patients. There's lots of videos in there. If you go into the professionals bit, which I think is my next slide, you can, there's the treatment guidance, there's the clinical searches are all there, but there's also all the letters and things that you can send to patients. There's lots of information on there. A lot of these hyperlinks on the right hand side there are leaflets that you can send. You can just send them out on AccuRx or patches, they're just there. There's ones that will self-populate with the patient details and stuff like that. So they're all on there. They're all downloadable. As I say, patient information that you can send to patients and then get them in. Obviously, as I say, it's written in 33 different languages, so there is everything that you need there for getting information out to patients, and then getting them in. So what was I going to say? Yeah. So optimizing treatment. The whole point behind West Yorkshire Healthy Hearts was simple and safe. Okay, I will go into how it slightly differs from NICE guidance, but simple and safe is the key here, and for that reason, I basically mandated anybody in my surgery to be using this guidance, even down to healthcare assistants. Really, I mean, clearly they're not going to be actually prescribing, but if we're all singing from the same hymn sheet, so they know. So even a healthcare assistant, if they see somebody, bringing in their home blood pressure readings that are high or whatever, they can actually be saying to the patient, yes, you need to go see the nurse, or you need to go see the pharmacist, but you're probably going to be starting on amlodipine. You might want to go and look at that, give them a leaflet. The guidance is simple and safe, and when we first introduced Healthy Hearts, there was quite a lot of kickback about, well, this is not NICE guidance. Why, and as I say, I've actually got the copies of NICE guidance later on, but I may as well go through it now. I think the argument for Healthy Hearts was that by having everybody in the clinical team singing from the same hymn sheet, you are going to get more people treated and more blood pressures down, and therefore hopefully more lives saved going forwards. It was the whole point of industrializing the process that makes it better because let's face it, we've all spent years following NICE guidance, and there were still lots of people with uncontrolled blood pressure. So the immediate, because we did get quizzed by NHS England and by their quality team and all of that, and we kicked back and said, well, NICE guidance isn't getting to them at the moment, so why not try something different? And the fact that it is safe, we're not using wildly different drugs, meant that it was well accepted. So I think it is the fact that everybody knows what the drugs are, everybody can use them, and you will get more people optimized by using them, is the argument for using the Healthy Hearts guidance. So nowadays in my practice, I have the ARRS pharmacists are running the searches on a monthly basis. And as I say, and I produce the league tables. As I say, I do have access to all the other clinical systems, and that's helpful. But yeah, nurses and pharmacists and ANPs, ACPs, and obviously all the GPs and that are all using the Healthy Hearts guidance. So we're all saying the same thing to patients, and I think there's a lot of power in that. Getting a consistent message. Obviously nowadays we have a lot of patients doing their own home blood pressure management. I don't know whether you in your surgeries do, but we have quite a large stock of blood pressure machines that patients take away for a week, and we send them the documentation to fill it. Either, well, obviously sometimes we give them bits of paper, but we try to do it via AccuRx, where we send them out the flurry to fill in their blood pressure measurements. So I do think that we've massively upped our game on getting getting patients to do their own stuff, but actually getting the information back to us and then acting on it accordingly. I think that's massively improved since COVID. Actually, I think patients are quite prepared to do their own thing, and particularly if you can lend them a machine. Then I think we've got about 30 machines in my practice at the moment, and some of which we've managed to get through grants, and some of which we've actually just bought ourselves because, well, it's just a good thing to do, really. And the patients book them out for a week, bring them back, bring their information back, and then we book them in with, normally with a pharmacist. I would say the bulk of our hypertension management is done by the pharmacy team now. Certainly, I'm not seeing them as a GP. I only get to see them right down the far end, really. And even then, I'm not really doing very much. I'm generally going for advice and guidance, or sending them to cardiology or something like that. But I'm doing very little of it. Probably, I don't know what your local community pharmacies are like, but certainly all our local pharmacies are now doing spot checks of blood pressures and sending them out with ambulatory monitors. And again, that information flows into the practice, and we have had problems with pharmacists tending to tag these onto the end of COVID jabs and things like that, where naturally a patient's blood pressure is going to be up a bit. So we've had to sort of temper their enthusiasm with that. But generally speaking, use your community pharmacy. They do get paid for doing this kind of stuff, and the ambulatory blood pressure. So get them doing that part of it and sending you the results. The next slide does actually have the Healthy Hearts guidance, but yeah, certainly every time they change a drug, you should be requesting a user needs, and that's either to keep an eye on their renal function or keep an eye on their potassium. But you'll see that on the next slide. But again, I'm quite happy for whichever level of staff are doing this to be requesting the user needs, because that's all they need to do. They don't need to be doing any other blood tests. Anyway, for those of you who haven't seen the guidance, it is here. Sorry, it's not very big, and actually I've got a slightly bigger version on the next slide. But you can see, in fact, let's just go to the next slide, because I'm going to come back to it, because it shows it a bit clearer. So there are 4 drugs. So it's amlodipine as first line, indapamide as second line, losartan, and then spironolactone is your 4th drug, and that is it. There are only 4 drugs. The reason these were chosen, and you'll see that it's amlodipine at 5 milligrams and not 10, and also you'll probably notice that ramipril's not in there, and that they were purely chosen to minimize side effects. We know that people get a cough with ramipril, and we know that they get swollen ankles. Up to 20% get swollen ankles with amlodipine 10 milligrams. So to keep it simple and to keep moving on, that's why amlodipine 5 was chosen, followed by indapamide. Actually, obviously, you'll realize indapamide's got a good chance of reducing the ankle swelling anyway. So, and then the losartan. Now, they don't, whoever is running this you don't need to do a user needs after amlodipine. So the first stage of blood pressure management doesn't involve any blood tests at all. You just use the amlodipine 5. If you then add in the indapamide or then the losartan in increasing doses, you should be doing the user needs in between, generally say 2 weeks after. And as I say, everybody knows that, and anybody can request those because it's part of the guidance. And then certainly with spironolactone, again, obviously monitoring. You don't go any higher than 25, not without good reason to. And certainly I don't go above 25 without asking for advice. So yeah, and certainly when you're at the spironolactone level, you need to be keeping an eye on the potassium level and the EGFR, obviously. If the potassium is over 4.5, you probably don't want to be using spironolactone, and that's when you can be using the alpha or beta blockers in there. But that's 4th line. Not many patients get there, to be honest, and by then they probably are going to be sitting in a GP's room rather than a pharmacist's room. I think this talk is more about, as I say, the lower, sorry, I don't want to call them lower levels of staff, but certainly, you know, pharmacies, nurses and stuff like that, you know, the vast majority of your blood pressure can be managed using the first 4 steps by the practice team, and using those 4 drugs that I've mentioned there. I'll just go back, because I sometimes forget things. So yeah, the sort of turquoise line on the left-hand side there, so they're not hypertensives. In the next line, you've got the mildly stage 1 hypertension. So they're the ones that obviously they all get lifestyle advice. You need to be looking for end organ damage, of course. So you know, these are the standard blood tests that you would do for somebody who you're now deciding is hypertensive. So you would do the lipids usually, you know, you can see the tests there, and the ECG. That's fairly, you know, standard procedure once you've decided they are hypertensive. And don't forget to code them. I am guilty. I've been there and, you know, go sailing off in my hypertension management without actually putting them on the hypertension register. But yeah, start them on amlodipine, add in indapamide. So further along, you've got stage 2 or even stage 3 hypertension. So certainly for your severe hypertension, where the blood pressure, you know, systolic is over 180, if you're genuinely concerned about these patients, you should be starting on 2 medications at once, and don't be frightened of doing it. I've had many patients now who I have actually started on both. If you want to be a little bit cautious, you could maybe start amlodipine 1 week and the indapamide the second week. But don't wait. If the systolic is over 180 and you don't think it's a spurious result, there's no problem starting them on both medications and telling them outright, look, you need them both because we've got to get this down. And I've not run into any particular problems. You're going to do the use and ease anyway, and you know, you get a good improvement in blood pressure by starting those. You'll see I've written in yellow at the bottom there, uncomplicated hypertension. There's still a lot of clinicians out there treating diabetics and things like that with the healthy heart guidance. It is not for people who've got diabetes, and it's not for people who have established ischemic heart disease. This is just for essential hypertension, and you must keep hammering that point home, because they still do it in my practice. I'll get a message coming through saying, oh, I've just done this with this patient, and I go back and say, they're a diabetic, it's not healthy heart. So you do need to keep reminding people that what this guidance is for. It is for uncomplicated hypertension, and there's plenty of those to go at without having to get into the world of diabetes or ischemic heart disease. So anyway, right, let's move on. So I've done that slide. So yeah, come back to why it's in. So this was nice guidance when we invented Healthy Hearts. As I say, it has been updated last year, and I've got that on the next slide actually. But it's not hugely different, but it's not simple. That was the problem with it, and that's why people were a little bit scared of it. So even though when you look at the 4 drugs on there, they're the same ones that are in the Healthy Hearts guide, apart from the beta blocker, which is, you know, not that. But so ACE inhibitors or ARBs, calcium channel blockers, diuretics, thiazide and thiazide. So they're the same drugs, but I think the way it was presented, you know, A or B, C or D, are you old, are you young, are you black, are you Chinese, are you, people just used to shirk away from it and go, ooh, I'll leave it to the doctors to do. Just the way it was. And Healthy Hearts thought, no, let's just make it simple. And it was only ever guidance. If you want to follow nice guidance and start somebody on an ACE or an ARB straight out because they're young and you think that's best for them, you can do that. We're not saying that you can't do that. And you could argue that that's, you know, a slightly better drug than starting them on amlodipine. That's fine. You can do that. But if you want all of your pharmacists and all of your nurses and everybody doing it, they're going to stick to Healthy Hearts because you'll get more done. Simple as that. So this is the nice guidance from 2023. And as I say, you can see that they have moved towards the Healthy Hearts guidance, which was really good. So this is what they released last year. So you can see that calcium channel blockers now in there. It's still not quite the same as Healthy Heart, but it's not far off. So yeah, I was actually really pleased when the nice guidance came out and thought, yes, they've seen the light, really. But if you want to follow nice 2023, absolutely fine. I still think that Healthy Hearts is simpler, but you're not going to be far off anyway. So yeah, so use that. And yeah, I think technically, you know, you've still got the, if they're young, black, African, Caribbean, whatever, then you can be started on losartan if you wish. I still stay away from ramipril. It's still there in the nice guidance, but there's no, personally, I think there's no reason to use ramipril when ARBs are around, really. And that's all we ever use at my practice now, and in my PCN is losartan. Titrate it up much like you would, and you don't get as many coughs coming back. Although you still get some, weirdly, but there you go. Personally, the very few hypertensions that I do see are coming to me when they're on the 4, or sometimes if they can't tolerate, amlodipine or something like that, and they've tried the other ones, they're the ones that are coming to me. And I might occasionally put in a beta blocker or something like that. But generally speaking, I'll be doing advice and guidance to cardiology at this point, particularly if I'm still, worried about their blood pressure and I haven't found any other reason for it. So, a lot of the time I am. So apart from maybe adding a beta blocker at step 4, I'm not really doing a lot else other than advice and guidance. And generally they disappear off to cardiology and get things done. So that's where I am with that. You can see on there what the targets are. The targets are the same in Healthy Hearts, really. I think we all know those, the 140/90 or the 135/85, and you can be a little slacker if they're over 80 or very frail. I think we all aim to get the blood pressure as low as possible without making them fall over. So I would say that the targets for NICE are fine. You can use those. And as I say, get patients to do as much as you can from ABPMs or HBPMs. I just thought I'd add in another couple of useful slides. This is actually on the Healthy Hearts guidance, but it's something that I think is worth highlighting and is often forgotten. So this is the sick day rules. This is not specific for blood pressure medication taking, but clearly you can see there's quite a few of the diuretics, ACE inhibitors, and ARBs are in there for your sick day rules. So if they've got continuous, vomiting, diarrhea for over 24 hours, then you need to be telling them to not be taking these medications, or they're likely to fall over or get more ill. So they are on the Healthy Hearts guidance, and I think they're useful to have anywhere, really. I personally don't think we bang on about these enough, and patients do become unwell. So make sure you're always advising patients accordingly. If you're putting them on these medications, that if they get sick and diarrhea, they need to be stopping them. So I'm hoping you recognise those already, but I just thought they were worth giving an extra show. I put this in, I didn't mention it before, about it is only for purely hypertensives, and please keep going. This again is written on the Healthy Hearts guidance. So if they've got diabetes, heart failure, or whatever, yes, clearly, ARB is going to be at the top. Beta blockers, obviously, for if they've got angina, and yes, again, if they've got CKD or proteinuria, you need to be starting them on an ARB. So don't follow the Healthy Hearts guidance if they've got other more comorbidities going on, because there are better drugs that they should be on first line than your amlodipine.